Well, welcome to the Encephalitis Podcast. Today I'm joined by doctor and writer, Dr Gavin Francis. Gavin qualified in medicine from Edinburgh in 1999 and then spent 10 years travelling all 7 continents. He's the author of an amazing 6 books of non-fiction, the most recent of which is Recovery, The Lost Art of Convalescence, which was published earlier this year. His books have been translated into 18 languages, so you have no excuses not to buy them wherever you are in the world. And he's the fellow of the Royal College of Physicians in Edinburgh and a fellow of the Royal College of General Practitioners. And he lives in Edinburgh, which for those of you that are watching from afar is in Scotland, in the United Kingdom, if it remains the United Kingdom. But he also works as a general practitioner or physician there in Edinburgh. And it is indeed his last book, this book here, that brings us together for this podcast. The concept of recovery and convalescence are things that I'm particularly curious about. And I think that we're going to cover many concepts over the next half an hour that will resonate with many of our listeners. So Gavin, welcome to the Encephalitis Podcast.
Oh, thank you. I'm delighted to have been asked.
Well, I'm going to get straight into the book because I genuinely loved this book and I've got so many questions for you and we've only got half an hour. So let's start, I think, from quite early on in your story. You had 2 experiences early on in life that appeared, at least from the book, related in some way to recovery and rehabilitation. First of all, you experienced meningitis as a child and the associated cognitive complications. And then 2 years later, you were an unlucky child, I have to say, Gavin. 2 years later, you had a bicycle accident resulting in you having to learn to walk again. And I was curious to hear a little bit more about these experiences and what you experienced with this contrast between the physical rehabilitation, being able to see something that's broken and not working, and perhaps what we can best describe as the more hidden disabilities of or experiences of something like meningitis.
Yes, no, thanks for the question, Ava. So yes, when I broke my leg, I was 12 years old. I fell off my bicycle. I splintered a bit of my tibial plateau. And I had to have surgery to put it back in place. And then my leg was immobilized in a plaster cast for a couple of months. And you can imagine, having your leg immobilized for a couple of months is challenging for any 12-year-old. And I had a very difficult summer that year. But really, what struck me about the process of recovery and convalescence was that journey really only began once the plaster cast was removed. And I could see my leg was really wasted in comparison to the other one. My bulk of my thigh muscles had disappeared, they melted away. The hairs on my legs had all grown very, very thick and dark, and the skin was like as white as bone. And I couldn't walk on it, of course. It was so weak. It wobbled and it gave way, and I found it really difficult to get back up to speed. But that was at a point at which the orthopedic surgeons thought I was healed. So the orthopedic surgeons were happy with me, discharged me, and yet I couldn't walk. And that process of convalescence was really striking because you could see my recovery in the bulk of my thigh. You could see it in the color of my skin, wearing shorts. You could see my sort of return to health very, very visibly. But as I also described, recovering from something like meningitis is so different because you look, to all intents and purposes, as if you're well. You look fine to everybody who's around you, but actually you have debilitating fatigue, you have headaches, you have difficulty concentrating, brain fog. And I suppose that built in then at the very earliest stages of my life was this appreciation that there's different kinds of convalescence and that every person and every condition is really unique in how recovery happens, and that we have to make space in the medical profession for that and to understand that. So yeah, that was a very kind of vivid example from early in my life, and I wonder if it influenced my decision to become a doctor. I don't know.
Oh, yeah, I think I was curious about that as well. And I think those are things that many of the listeners and viewers that have been affected by encephalitis will really resonate with this,
Mm.
this hidden nature of brain injury, and when something goes wrong with the brain, the fact that other people can't see it.
Mm-hmm.
And I remember reading a quote actually. It was from somewhere rather random, like the National Union of Journalists or something, but they said that the foremost type of discrimination is that of not being believed. And I think that's another thing that people with these hidden disabilities are often, well, you're a malingerer, it was 6 months ago, come on,
Mm-hmm.
why haven't you sorted yourself out? But you
Mm-hmm.
touch upon the concept of rehabilitation more broadly quite early on in the book, where you make
Mm-hmm.
it clear that rehabilitation is to make someone as fit as they can be, I think is the term that you used.
Mm-hmm.
And I found that really interesting, because I think a lot of patients who go into rehabilitation think that the outcome of rehabilitation will be them returning to the way that they were before. And we know that that's not always the case. Can you say a bit more around that?
Yes, of course, there's people can feel an awful lot of pressure to recover to the extent that the level of health or the level of fitness or the level of social engagement or the level that they were operating at professionally, they can feel a lot of pressure to try and return to that. And I think it's really unhelpful, actually. It's a really unhelpful perspective. Our bodies are changing all the time, even without injury or without an infection like encephalitis. Our bodies are changing and aging, and what we can expect of them changes as we get older. And the effects of both injury and of this kind of infection can be so enduring and so deep-seated that I always think it's much, much better to think in terms of what potentials we have in our recovery. And there's a wonderful book by a rehab doctor called Christopher Ward. Chris Ward wrote a book called Between Sickness and Health, and in it he describes his perspective in rehab medicine as being one of encouraging possibilitation rather than rehabilitation, which is a much, much more helpful way of thinking about it. Do you know, this idea that health is an extreme to be reached, and that it's like at the top of this ladder that we all have to try and climb up to this ladder to reach health, I think is a profoundly unhelpful one. And it's much more in keeping with my experience as a GP, helping patients over the years to think of health as a balance between extremes. And having and suffering a severe illness or injury just means that we have to find a new balance. We have to find a new balance of what's possible, and we have to find a new kind of equilibrium that we're capable of sustaining. So yes, let's jettison these old ideas of rehabilitation being about some return to an impossible perfection, and think about it instead as about finding a new balance and learning to live with your body the way it is now.
I couldn't agree more. I think that's a really refreshing perspective. Yeah, I many years ago, I used to go into brain injury rehabilitation units around the country, and you'd often, you'd have the kitchen, and there'd be some, I don't know, 20-stone bruiser who'd sustained a punch in the head down the pub, and teaching him how to make a cup of tea and I don't know, make fairy cakes or something. And it struck me that what we should really have been doing to help with his rehabilitation was helping him play darts again, and work out where his new norm was in terms of how many pints he was going to have down the pub with his mates or something. It always felt a bit, off center, really, that we were putting people into the box of rehabilitation rather than, I think things are much better now. I think there's more kind of transitional and community rehabilitation that does look at that, but that used to strike me 20 years ago. But you also use a term in the book, which I absolutely loved, called no hierarchy to suffering. And I think this is something that really resonates with myself and the team at the Encephalitis Society, who try, terribly hard on a daily basis to help people around the world that have been affected by encephalitis. But of course, you can't always help everybody. But I think we're always struck with how profoundly different people's experiences and approaches to illness can be. Can you talk a little bit more about that and how this no hierarchy to suffering that you talked about?
Yeah, sure. So it's when you're at work as a GP, you meet people in all kinds of situations all the time, with the most trivial of health conditions and the most profound, life-changing, debilitating, disabling of conditions, and everywhere on the spectrum in between. And what strikes you, or what strikes me certainly again and again, is that it is impossible to predict with different individuals how they're going to respond to these kind of situations. So, you know, I've met people over the course of my career who've been utterly devastated in terms of their mental health and their resilience by the breakup of a love affair, for example. I've met other people who've taken the most disabling strokes or rapidly progressive Parkinson's disease or some other condition that objectively looks much, much more serious or life-limiting. I've seen people take those kind of diagnoses in their stride. And so I've learned over the years, I think, never to expect there to be some kind of objective scale of who's deserving of compassion or pity or help than others. Everybody's got a different way of coming to terms with what's afflicted them, and everybody's got a different way of approaching their own strengths and their own path back to recovery. And I see my job as a doctor very much as a kind of midwife of change. So you're supposed to really help people change back towards the best version of themselves that they can be. And for some people, as I said, that can be really over years helping them overcome something that to another person might seem quite trivial. You also see over the course of my career, I see that sometimes the most difficult or debilitating problems are not the ones that take the most time in clinic or that take the most work in terms of recovery. Sometimes it's again, something quite trivial from the outside, like tennis elbow, say, can be utterly debilitating and life-changing for somebody who was living independently and suddenly is unable to. They're unable to open a jar, they're unable to turn the keys, they're in their door. What from the outside might look like a trivial thing is not actually trivial at all. And so I'm always very careful now to, when people tell me what's suffering them, I say, how does that affect you? And that gives you a really interesting insight into the effect of even apparently or objectively quite trivial complaints can be really quite devastating to different people.
Yeah, I think that's really really important. I know in our work often, and you talked about being discharged, and not being able to walk, and I know quite often sometimes our people are discharged, and in the clinical world it's like, well, you know, they've got mild difficulties or moderate difficulties or profound difficulties, and actually some of the people with the most profound difficulties are not the ones who are struggling the most, because actually their levels of awareness often are not very high in terms of the difficulties that they're facing. Quite often that's more of a problem for the family members. But often those that are struggling the most are those that clinically would be considered mild in terms of their outcome. But on a day-to-day basis, their emotion, their psychology, their sense of self has been so profoundly changed that they're really struggling on a day-to-day basis. So I think that's something that really resonates with us.
Yeah, I can imagine if you're being classified by the rehab unit as mild, but if you're before your encephalitis, your function was at a very high intellectual level, or you had a very demanding professional job, the inability to go back to that job might be utterly devastating.
Yeah.
Whereas even somebody with moderate conditions, if they're able to go back to live largely the life they were living before, they might feel quite, that they're adjusting quite well to their illness. Yeah.
You moving on to this topic of convalescence. I am sadly old enough to remember when we had convalescent homes available in the UK, and indeed cottage hospitals as well. I was raised in Falmouth in Cornwall, and we had a little cottage hospital just down the road, where this is where people who often went after being very poorly in hospital, that's where they'd go for their recovery, their rehabilitation, and they'd spend time recuperating. I vaguely remember my dad having a DVT. He was a big drinker, he was an alcoholic, he had a DVT, but I remember him going from hospital into a convalescent home and me thinking, oh, that's a nice thing, you know, someone's taking care of him. Under the Thatcher government, I think most of these were culled, except for the hospice movement, which you talk a little bit about in the book. But I was really surprised to learn from your book the number of hospital beds in the United Kingdom has halved since 1988, from 300,000 to 150,000. How can we possibly justify the loss of so many acute beds and also places that people go to recover and recuperate? You know, we're constantly talking about the NHS and bed blocking. I mean, surely, I mean, it can't just be me that this is obvious to.
No, it's purely financial, and it's quite cynical political shifts, really. It's been justified again and again by political elites because it's been argued that advances in, for example, keyhole surgery and advances in improvements in community services make it much easier now than it was in 1980, say, to discharge people after surgery into a supportive environment at home. But of course, those of us who work in the community rather than hospital know that that is completely untrue. Actually, we see these constant problems you referred to there of so-called bed blocking, which actually just means that there is inadequate services in the community to allow a patient to safely get home. So we have a government that stripped out finance from social care. We have a government that is obsessed with tabloid-friendly medical issues, like, for example, chemotherapy or fancy surgical procedures. And you never see the front page of the tabloids screaming about the diminution of community physiotherapy or the diminution of community mental health. But these are the things that allow people to get home safely. And they also, if you're struggling in the community with very severe mental health problems, the burden of suffering and unhappiness in the community is huge. But you're never going, you're the CEO of your health board is never going to find out about it. It's never going to make the headlines the way that a queue of ambulances outside A&E make the headlines. But this constant stripping of capacity for inpatient care has enormous consequences in terms of the suffering it causes out there in the community and the difficulties it introduces into the jobs of GPs and district nurses like myself, who are trying to manage these patients in the community, patients that 30 years ago would always have been managed in hospital. And I am daily in my work faced with the problem of somebody who is quite frail, quite isolated, not managing at home, elderly, has multiple medical difficulties that 30 or 40 years ago would always have been managed in hospital. And yet there are no beds for me to admit that patient to, even if they just needed something like a cottage hospital bed for a couple of nights. And it's something that's very starkly obvious to me because I move between a city practice where I work in the centre of Edinburgh, and also I work sometimes in the small islands of Orkney or the Hebrides in Scotland. And these much smaller communities do still have community hospitals, and because they have to, because the ferries don't run all the time. And so you need somewhere to put the patient if you're on an island. And the transformation of the way it makes you be able to practice medicine is wonderful when you do have something like an intermediate care bed that you can admit somebody to. So how you asked me how it's justified, I don't think it can be justified. It can be justified because again and again, unfortunately, our political elites are unwilling to be honest with the electorate about how much an adequately funded NHS would cost, and they're unwilling to then translate that into the requisite taxation changes that would require it. So whenever election time comes round, all the political parties of every colour are always saying how important the NHS is to them. But then once the election is out the way, they get on with stripping it in the most tabloid friendly way that they can without causing too much of a ruction. And that's why we've seen such a, for me, really quite terrible diminution in the community services that I have access to as a GP.
Mm. Well, who knew that I was going to be politically affiliated with your views as well as some of your views that you share in the book. But you also talk about in the book that it's impossible. So this is in a similar vein, that it's impossible for you as a doctor to be able to arrange admission to a psychiatric or mental health hospital on humanitarian grounds. And by that, I think you mean to ease someone's suffering. And the only way that you can help these patients into these hospitals is on the grounds of safety. And I'm guessing you mean by that they're either a danger to themselves or to other people. It seems astonishing that we can't take preventative action as people's situations might be escalating, that we have to let them get into crisis before we can intervene.
Yeah, I mean, we do have this system, certainly in the area where I work, we have a system of community mental health care called the Rapid Response Team. And so in an ideal world, if somebody is undergoing a major crisis, a psychotic illness, say, or they've become suicidally depressed and made an attempt on their own life, I can make phone calls and that can have this rapid response team, which consists of a psychiatrist and community psychiatric nurses, engage very rapidly with that patient within the same day or by the next day. Of course, these are people who will come and chat to the patient and prescribe medication in their own home. Now, we seem to have lost something when we jettisoned the old-fashioned term asylum, and because, of course, the word asylum means place of safety. And it's got a terrible name to it now because we think of these Victorian asylums where people were locked up without adequate cause, and essentially the key was thrown away and there were no adequate, really supportive services or care given to them. But the word asylum should mean a place of safety. And it's really tragic to me that if somebody is in acute distress, they're in a home situation that's possibly either caused or majorly contributed to that distress, either a domestic situation or even an environmental situation. There's lots of triggers all around them in that home. And what I really need to do is get that patient to a place of safety. So, but I can't do that. What I can do is phone up the rapid response team and they'll come around and chat to them in their own sofa. So the only way I can get somebody admitted to psychiatric hospital is if they're actively suicidal or they're actively psychotic and we're worried that they're going to attack somebody or they're going to drive their car into a wall or they're going to do something which is a danger to someone else. And I think it's really tragic. I would love to have the capacity available within the mental health services that I could admit somebody who was just really, really deep in suffering, either through despair or through psychosis, but wasn't a danger to themselves, but still needed a place of safety to be in order to heal or in order to get perspective. But unfortunately, that's not available in the mental health services as they're presented to me as a GP.
Yeah, and I'm sure that would be a much more cost-effective way of, treating patients rather than all the economic costs associated with people being in these kind of chaotic crises.
Yeah, I would think so too. I would hope so too. But I worry that even if it wasn't economically better to do that, even if it did cost more to have a place of safety for people, then I still think we should do it because it's about the relief of suffering. And what is the purpose of the NHS? What is the purpose of medicine other than to ease suffering? The word patient means sufferer. And so if we can't build ourselves a system dedicated to easing suffering, then we're just building a system that's about firefighting.
Yeah.
And it's not a system that's particularly pleasant to work in, and it's not a system that's pleasant for the patient to be in.
Yeah, absolutely. Sticking plasters don't always help the wounds to heal, do they? Underneath, You talk about the practice of medicine and perhaps what the ideal doctor might look like. So I was intrigued. I thought, is the one, and what might they look like? I have to say, I've just recently found a doctor who I do think is my ideal doctor, and I'm very relieved. The surgery that I go to, I can be in quite a good state of mind when I go there, and then I become quite angry before I've even seen the doctor, because it's just littered with notices everywhere that just seem to fuel an ire in me, because it's don't lean over the counter, and it's they've got posters up saying you've got 2 options today. You can have an appointment with the GP or the police, and I'm reading all of this, and it's like, really? I was fine when I walked in, but now I'm kind of feeling a bit angry. But this brings me to my point, which is something that I do lecture about, which is about narrative medicine, and it is a bit of a passion of mine. And by narrative medicine, I mean that by listening, we try to gain a deeper understanding of people's experiences and the emotions that are likely to have influenced their health. There's a particular person called Rita Sharon over in the United States, whose work I particularly like around this, if anybody wants to Google it and hear a bit more. But what do you think doctors can learn or achieve by practicing a narrative medicine approach with their patients?
My understanding of it too is that narrative medicine is about understanding the place of the suffering or the illness in the patient's life and the story of their life, and trying to find out more about that story. And it's I alluded to earlier when I talked about that question of saying, well, so how does this affect you in your daily life? What difference does it make? Quite often it's really useful to ask a patient to talk through a normal day for you and tell you, what do they do after they get up, and then what do they do, and then what do you do, and then what you do. And so my own view of narrative medicine is that it's just good medicine. I don't think we need a special word for it. I would rather we didn't have a special word for it. And sadly, we often don't have enough time in the NHS that I practice in, just because it's optimized for maximum value for money for the taxpayer. And so that means about 2,000 patients for every full-time GP. In some places where it's very pressurized, it goes as high as 2,500 patients per GP, which translates roughly as about 10-minute appointments. And it's very difficult to get a proper grasp of the story of a patient's life and the place of their illness within it in the space of 10 minutes. But it's good medicine to try. It makes the medicine so much more satisfying to practice, and it's actually far more effective as well. So yeah, I'm all for it. I'm all for encouraging it. There's a wonderful perspective on GP consultations, which is that within every consultation, you should try to find some point of connection with the patient outside the bounds of the consultation. So whether that's talking about their pets, or whether that's talking about where they're going on holiday, or whether that's talking about their hobbies, or whether that's talking about what they had for dinner last night, to create a space where you can connect as human beings that isn't just in a direct doctor-patient transaction, really enriches the consultation. And when you make an effort, even when time is pressured to do that, it's quite remarkable how many other things and stories and reflections and even treatment pathways end up unfolding from making that space. So the short answer is yes, I think it's a good thing, but I'm not sure we really need a special name for it. It should just be called good medicine.
Well, that's a fair point. Maybe because that's another lost art that we have found a name for it now. I don't know. Bringing us back again for the third time in this podcast to this no hierarchy of suffering. You described a scenario in the book where you telephone a patient, he's out cycling, and you're giving him a diagnosis of, I think it was anemia. And he suddenly on the phone to you became quite breathless, quite unwell. And I'd like to talk a little bit for a minute about diagnoses. When I first started working in this field, I remember a doctor asking me, well, is a diagnosis important, Ava? And I went, well, of course it is. Of course they want to know what's wrong with them. And do you know what? I've had some life experiences since then where I'm not sure. I mean, I've lost a couple of people close to me over the last few years. Many of us have. But it almost felt like when they got their diagnosis, something changed and their trajectory changed. And I don't know. I'm not so sure that people always do want a diagnosis or that it's a good thing. I don't know. What are your thoughts around that?
Yeah, the words that we give our suffering and the words that we give ailments are really powerful, aren't they? They're kind of like magic spells, you know, and I don't think there's an easy answer to that, Ava. I think it depends so much not only on the diagnosis, but also it depends so much on the individual, and then it depends again on the phase of the life that the individual is in. So that was an example of somebody who didn't know a bit about medicine, and so to be told that they were profoundly anemic, that meant something to that patient, and they suddenly, every kind of little catch in your breath that you feel when you exert yourself anyway became freighted with all these anxieties because of the knowledge of how profoundly anemic they really were. And it's a really vivid reminder for me that what's so important in illness is our understandings of illness and our beliefs about illness. And they massively color and filter our experience of our bodies. So if you believe that you've got a minor self-limiting condition, you'll just push yourself and push through all kinds of things. But if somebody tells you that you're breathless because you've got a tumor in your lung, that breathlessness means something very different to you every time you feel it. So you might have just been ascribing your breathlessness, for example, to the fact that you'd had a runny nose and a cold last week. And then someone tells you, no, actually, it's because your lung capacity is halved. That knowledge profoundly alters your interpretation of your experience of breathlessness. And that goes for everything. It goes for people who have sciatica, who characterize their sciatic pain just as if you say, oh, I've just got a trapped nerve, they might sort of shrug and move on from that and try to mobilize their back. But if you tell them, oh, well, you've slipped a disc and it's pressing on your spinal cord, people are paralyzed with fear and scared to move. So how you characterize an illness has a huge impact on not just recovery, but also how it's experienced. So going back to your question of is diagnosis a good thing or is it not? I think it varies very much in the diagnosis. Some diagnostic categories are pretty hazy, to be honest. They're not very good. There's a whole load of immunological diagnoses that we don't really understand very well. You know, one end of the spectrum, we've got quite obvious ones like rheumatoid arthritis, say, or ulcerative colitis that we understand a little bit about, and we understand that the immune system is attacking the body in some way. But then there's other kinds of autoimmune conditions like, for example, demyelination that we don't really understand very well. And sometimes it's better not to give a firm diagnosis. If you tell somebody who's had an episode of demyelination, oh, you've got multiple sclerosis, that's a profound life-altering diagnosis to give somebody. But actually, it might have just been a one-off. It might never happen again. And so you have to be very, very careful in throwing around words like that. In my own experience is it's quite a good idea just to gauge very gently, testing the water, how much a particular patient wants to know. And that, of course, will vary depending on what the diagnosis is. Sometimes you've got an obligation to tell people even if they don't want to hear it. But in that situation, I would be extremely, extremely careful, and I would probably work up to it over several conversations.
And of course, sometimes there isn't always a diagnosis. I think sometimes, you know, the media often leaves us to believe, you know, people go into hospital and there's always a diagnosis. This is what's wrong with you. And of course, we know that isn't always the case, and that can be profoundly frustrating for patients and caregivers.
Yeah, absolutely. And I would hate to give the impression that medicine has all the answers. Definitely doesn't have all the answers. It has a lot of answers, and we're very, very good at sort of picking out and identifying particularly nasty, progressive, life-threatening diagnoses. But there's a massive swathe of kind of grey, hazy, fuzzy diagnoses that people move in and out of through their life that are far more indistinct. And as a GP, you certainly make your peace with that very early, and it can be quite difficult sometimes to prepare some patients with black and white thinking for that reality.
Yeah, I'm one of those black and white people, I'm afraid, but you, again, throughout the book, you return time and again to the concept of, and we've touched upon it already, how people understand and make sense of their illness experience. Sometimes that's positively, sometimes that's negatively. But you going back to some of your patients, you recounted this story of two men who suffered traumatic near-death experiences, but who interpreted and acted upon those experiences in profoundly different ways. And I think at the end of chapter 10, you say that accepting that different stories are even possible and that people's stories can be rewritten is a powerful step in the right direction. And I think by that you meant in the direction of recovery. Can you tell us a little bit more about that?
Well, that particular example is the story of two men who both collapsed with heart trouble, with a heart arrhythmia, and had defibrillator shocks to the heart, which brought them back to life. And both of whom then had implantable defibrillators put into their hearts, so that if the fibrillation ever happened again, they would be shocked back out of it automatically. And I had one patient who just felt like this was a magnificent sort of restoration to life. He felt utterly rejuvenated, and he thought, I should be dead. I was dead. I was lying there in the car park dead, and these paramedics brought me back to life, and what a wonderful life it is. And spent time eating fine food and going on holidays and loving time with his grandchildren. And I had another patient that had almost exactly the same experience, but instead of being rejuvenated by it, was mortified by it. And suddenly the awareness of the vulnerability and the fragility of life was profoundly upsetting, and became very, very anxious, scared to go out, scared to be left alone, just because that experience of knowing that your heart could stop was so terrifying. And I thought that was really amazingly good reminder as GPs that the stories we tell ourselves and the stories we understand and the way we interpret the objective events of our lives have these huge influences on the way we experience our life, and on how happy we feel, and on our own perspective on what's happened to us, and our own hopes for the future. And so it reminded me to try and not only understand the story of my patient, where they're coming from, but also to try and nudge people where I can in the right direction. And by right direction, I mean in the direction of more flourishing, more happiness, more contentment with your situation, even if it's limited. For example, now you've got a implanted defibrillator, now that you've got this heart vulnerability that you didn't have before. But look at all these possibilities that are now open to you that wouldn't have been open to you even 30, 40 years ago, before such defibrillators existed. So that was a really good reminder for me of the importance of stories.
Absolutely. And I always hope, if anything were to happen to me, that I'd be like that first gentleman. But I don't know. You just don't know, do you? Because you can always think of these things and think, well, we judge all the time. Like, well, if that was me, I'd do this. And a couple of the times that things have happened to me, I've reacted completely differently to the way that I said that I would have done, which was, a huge surprise. But we're nearing the end of the podcast, Gavin. Before I finish, and I am going to finish with what I took away, some wise words from your book. But I'm going to lighten our mood a little, because we've been talking about some really serious things here: health, illness, politics, the government, God help us. And so this is your little desert island disc moment,
okay,
which I love doing with people. If you hadn't have been a doctor, what would you have been?
I think I probably would have been a geographer. I like making maps. I like making sense of the world through maps. And if I could have got into that, then I think I would have done it. Not just physical geography, but social geography too. Mapping the way human communities move and live on the land. Yeah.
Okay, hence all the maps that we can see behind you.
Yeah, I love those. Yeah.
Oh, okay. Favorite book and why?
Oh, that's really, for a writer, that's an almost impossibly difficult question, I think. Because it changes all the time, depending on what my current preoccupations are. But probably at the moment, I'm thinking a lot about medicine, and I keep going back and back and back to a wonderful book from the 60s by John Berger about general practice called A Fortunate Man. So it's a book, John Berger is sadly dead now. He was an art critic, an art writer who spent 6 weeks living with a GP and sitting in on every consultation and doing every home visit, every emergency call with the GP in the late 60s. And to have somebody so trained in acute observation watch the process of GP consultations and then write about them, not as a fellow clinician or not as a critic, but as somebody who appreciates art, is really illuminating. So that would be my vote, A Fortunate Man by John Berger.
Oh, okay. I'm going to look that up. Yesterday, the team and I, we do something once in a while called Neuro Cinema, where we all come together as a team. We bring food and we watch a movie that's usually something neurologically related because of the work that we do. And yesterday we watched Oliver Sacks' His Own Life. I don't know if you've seen that yet. So
no, not yet. No.
I genuinely recommend it to you and any of the listeners. It was
I love Oliver Sacks. Yeah.
Really moving couple of hours. And yeah, again, I mean, I had the fortune of working with him very briefly when he came over to the UK many years ago. But I think he's hugely influenced my interest in patient narratives and neurology and all of those things. But anyway, so I'm putting that out there for anybody who wants to do something
thank you.
Over the weekend. But your question's not yet finished. Favorite singer or band?
Oh, again, varies all the time. At the moment, I'm listening to a lot of King Creosote. He's a singer-songwriter from Fife in Scotland. Wonderful, very kind of beautiful, sometimes quite melancholy, but a really elegant songwriter. So yeah, King Creosote.
Okay, that's another thing for me to Google this weekend. Not heard of him. And finally, last meal, if you had to choose one.
I think I'd like takeaway pizza on the harbour with my kids.
Oh, that's amazing.
Yeah.
How many kids have you got?
3.
3, okay.
Yeah.
Right, well, I said I was going to finish up with some wise words from your book. I think there's a lot of wise words in it, but a couple of my favourites. No one is getting any younger, and all of us would do well to remember that health can never be a final destination, but a balance between extremes, different for everyone, and whether we reach it or not depends on our goals and priorities as much as it depends on anatomy and physiology. I really liked that. And the second one was, don't expect all doctors and nurses to be the same. It's good that they're different. They're fallible individuals and are usually trying their best. And for that, we thank you all, Gavin. We've covered a huge amount. We're extremely grateful to you for taking the time to chat with us. So thank you so much for joining me today.
Yeah, thank you, Ava.
The Encephalitis Society remains at your service, and so if you need any support or information, our teams, of course, are always there for you. Go to encephalitis.info for contact details or to chat online with any of the team. We hope that you've enjoyed this podcast, and as always, if you can support our life-saving work, we'd be extremely grateful. So please visit encephalitis.info/donate. And don't forget, finally, I mustn't forget, buy the book. It's available from most online retailers if you simply Google it, Recovery, The Lost Art of Convalescence by Gavin Francis. And I genuinely, look, viewers, you can see all my notes here. I haven't been able to talk to him about all of these things that I've flagged up, but there's a lot in it. It's really rich for such a tiny little book. It won't take you very long to read it. So please do go and buy it. Thank you, everybody.
Yeah. Thank you very much for having me on your program.
You're so welcome.